this book a couple years ago, and if people haven't read it, it's really a wonderful overview of health disparities and trying to improve health in an unequal world is the subtitle of it. So I'm going to move on to the next part of the talk, which is going to feature a little bit of what we've been trying to do locally to improve the care that we provide, especially to our new onset patients. And just wanted to start off with acknowledgements, especially Priya Prahalad, who let me borrow some of her slides as she's put together some of her pilot data, and also then just acknowledge the NIH grant, the Stanford Diabetes Research Center, and then also we have a Helmsley Charitable Trust grant for an exercise ancillary study that Desi Zavrieva is leading as well. So this, the name of the program is Teamwork Targets Technology and Tight Control in Newly Diagnosed Pediatric Type 1 Patients. And what I'm showing you here in this curve is what are the observed hemoglobin, or were the hemoglobin A1c results in all of our new onsets from 2014 to 2016. And I imagine this is fairly similar most places. Our patients get diagnosed, they didn't know they had diabetes, obviously, their A1c is high, it comes down, bottoms out somewhere between 4 and 6 months as they're in the honeymoon period, and then you kind of slowly get this drift back up for a variety of reasons. And so what we said was, well, gosh, if we can get the A1c down, can we keep it down at that goal of 7% or 7.5% at the time, which is what the ADA guidelines, ISPAD guidelines are. And so we came up with this proposal, and we have really three specific aims part of this program. One is to implement the 4T education and care program to reduce the rise in A1c trajectory, and I'll talk a little bit more about how we're operationalizing that. And then second, we're really fortunate, as you are, to have pediatric diabetes psychologists. There just aren't that many of them, and we're really fortunate that we've got, we actually have 4 plus a postdoc. And so Corey Hood and Deanna Naranjo, Jesse Wong and Molly Tannenbaum. Jesse and Molly are both on K23s, but as part of this, we wanted to take a systematic approach to monitor psychosocial and patient-reported outcomes. And then the third part of it, which I'll talk a little bit more about, we need to develop and test an automated system to identify need for insulin dose adjustments between quarterly visits. So is there a way to be a little bit more precise with how we care for patients, but do it in a way that doesn't overwhelm our staff? Otherwise, that's not really going to work. And this was funded by an R18 mechanism, which is a pragmatic research trial. So the funds can be used to set up the research study, but they can't be used to, say, go out and hire 5 new diabetes educators. And this Priya did get a paper published just on explaining what these A1c trajectories were. That was in DTT a couple of years ago. And so another nice paper is from Diabetologia a couple of years ago, and basically making the point that after you reach a certain point in your diabetes care, that your A1c tends to level out in pediatric diabetes. So again, with that idea of if we can keep your A1c lower from the start, perhaps we have a better chance for long-term success than to bring it down. And so Priya also has a project she's working on with the SWEET Registry, where they're looking at this, again, the same type of curves. And what's really interesting is they broke it down by different regions: Northern Europe, Southern Europe. You can see we're doing better. And then South America, Asia, Middle East, and Africa in the yellow. And then we've got North America, Australia, and New Zealand. And these are, not population representative in any way. These are just happen to be the clinics who are contributing data to the SWEET Registry. But again, you see that same shift and increase in hemoglobin A1c as the partial clinical remission or honeymoon period wanes. But in North America, we're seeing that, again, that we're starting much higher and staying higher than the other groups. So raises the question, what can we learn from our different colleagues across the world? what are they doing, what might we learn, and some of that could be clinic level, some of it could be systems level, national level as well. So just briefly, this probably compares to how most people have been doing diabetes education, and then I've got a slide later on how we've adapted things. But we have the patient get diagnosed, you meet with the family, begin the explanation of what diabetes is, what we need to do. We then have 4 to 6 hours of outpatient education. We've got then a system where there's daily communication until you have that visit about hopefully 1 week after diagnosis, and then you again visit with the MD or nurse practitioner, the diabetes educator, RD, social worker, or psychologist. You have a 1-month follow-up, and then every 3 months. You can get started on technology months, years, no systematic approach necessarily to getting started, but it would be offered when the family wanted it, or when the doctor or diabetes team thought the family was ready to hear about it. So what I'm going to tell you now is a little bit about our pilot study. Some of this data we'll present at the ADA, but just to try to explain what we're doing. This is directed at youth with newly diagnosed type 1. What we have done for the last couple of years is offered the opportunity to start on a G6. And what we do then is provide a 1-month starter pack, a transmitter, 3 sensors, and a receiver, and that's been provided by Dexcom. And then with the idea that we have ongoing coverage applied through the use of insurance, so that they're able to then sustain that and continue to get it. And that created a little bit of a complication that we fortunately did find a solution for, but I'll come back to that. And then later, not as a first step, we began the second part of the program, which was the opportunity for remote monitoring. And I'll talk a little bit more about that as what that exactly means. And then the youth who elected to start on the Dexcom then had an additional 1-week follow-up with a nurse practitioner. Most of that's been by telehealth, although we did have some that were in person prior to COVID. And then in the remote monitoring study, I'll talk a little bit more of that. We had weekly CGM review by the care team. So basically, we included everyone who was within the first month of diagnosis, less than 21, and plan to have ongoing follow-up with our practice. So just as far as what that looked like, we had in this almost 2-year period, had about 136 youth with new onset type 1. There were 123 who got approached, 119 got initiated on CGM. There were 4 who declined. They tended to be adolescents who didn't want to be wearing something. Subsequently, 1 of them did decide to use CGM. Now, early on, we had 13 who were excluded, and 2 were excluded because they were going to then be traveling internationally. They ended up eventually starting CGM later. We had 11 who were on public insurance, and initially, because we weren't able to have funding to be able to continue to have the patients on CGM, we had to make the decision: are we going to start these kids on 1 month of CGM and then have to say, gosh, I bet you really like that, it worked well, but now we don't have any more funding for you to keep on CGM? Or what we decided painfully was to say, we can't start you on this because we wouldn't be able to sustain it. We were able then, PRIA was able to get a grant, one with the R18 grant, but then PRIA also got a grant from the Packard Foundation locally to be able to provide CGM for up to a year to these patients with public insurance. So we were able to go back then and get all 11 of those patients started on CGM, which made us feel better. And we've got that as part of the program going forward. So with the 133, just as far as the remote monitoring, we didn't have it up and running initially. And again, this is a pilot study to show feasibility for the NIH grant. The 85 who we approached, 84 of them consented to be in the remote monitoring, and 1 declined to be in remote monitoring. So now I'm just going to give some descriptions of the pilot data. And we had 133. We do have 133. These are the 122 who will have at least 6 months of data. Hopefully, we'll update this soon and have data on the full cohort. But 122 of the 133. Fairly typical for, well, this is our clinic population. That mean age was about 10, slightly more males than females, about 76% of private insurance, 38% were non-Hispanic white. The initial A1c was 12.2%, and median time to CGM initiation was about 9 days. So this graph here, I showed you before, this this black line are the 272 patients that we had diagnosed in that period of 2014 to 16, and you can see that this is what it looked like with the black line. And then what we have is the 122 who were diagnosed as part of this program. And interestingly, they had a slightly higher A1c at start, but then it came down very similarly. But then we're able to keep it down through the course of 15 months is the farthest out we have data. So when we did an adjusted analysis, we see that there is an improvement. This was adjusted for A1c, age at onset, Hispanic ethnicity, and insurance. I think it's probably, this slide is better because it's an unadjusted A1c, because again, we had a higher A1c to start with, and I think that threw things off a little bit. But when you look at what the difference is at 6 months, 9 months, and 12 months, we've got about a 0.5% decrease in the A1c from starting CGM early and having a slightly different approach to diabetes care and the targets that we set. So also have data, and we're in the process of refining this, just looking at GMIs over the course. And it's kind of interesting because it takes us time for that A1c to drop, but in contrast, your GMI, which is based on the 2 weeks of CGM readings, comes down pretty darn quickly. And so by 4 weeks, 6 weeks, we've got a GMI that's where you would expect it to be below, for the most part, below 7.5. And then this graph just looks at what's the percent time in range. And we are seeing a drop off here, but if you look at 52 weeks here, we're still around 60% or so. So as far as discontinuations, we have 880 total visits for these 122 patients. There were 35 visits, only 4% without CGM use. Some of them were insurance issues. There were some who didn't want to wear CGM or take a break. There were some issues with technology, parental preference, some unknowns, and then some others. And there were 3 patients who were not on CGM. 2 had public insurance, and there were supply issues. And then there was 1 lost to follow-up for a year prior to the most recent visit out of 122. So I mentioned this remote monitoring. What the heck am I talking about? The last thing any diabetes clinic wants is to be following in real time 1,000 patients with their CGM data. It just wouldn't be possible. So what are we talking about? Well, we're talking about review a caregiver, and in this case, it's a certified diabetes educator at frequent intervals to provide education or make dose changes. We're doing this asynchronously at a weekly interval and using MyChart messaging as well as telehealth to communicate with families. And then we also are working on integration of the data into the electronic medical record. We've got Epic, and then to build some tools to facilitate that process. And this is where, with that third specific aim that I was talking about, we're very fortunate to have a faculty member named David Schenker, who's actually he's a Ph.D. in math and has a primary appointment in engineering school, but he's also has an appointment with Children's Hospital in our division to work on big data and process improvement. And it's really been wonderful to work with him and his team of engineering graduate students as well for some of this work. So we've got this is a paper by Rajiv Kumar, who is still an adjunct faculty, but he moved to be full-time at Apple, and he still sees patients in clinic a couple of times a month with the fellows. But he developed this system, and here's the publication if you want to read more about it. So it basically used Apple Health Kit. We've got the patient wearing the CGM, the data can go up to the cloud via the G6, then via the Apple Health Kit, able to get it down into Epic, and we're able to then see that and be able to communicate back to the patient. And I'll show you a little bit more about how we've had some iterations. We're on our 4th phase, so I'll show you the first 3 phases here on how we walk through this. First with clarity, then using CSV files through an R-based tool and flagging patients who are requiring review. So what this phase 2 looked like is we would have, say, the top 20 patients to review, and we had different metrics. What % of time was the CGM being worn? And if it was less than 75%, then you'd get a red flag. And then what was the % time in range? And you could set various flags on what level you wanted to be alerted at. What was it the previous month? What's the % change? What's the % of time less than 54 and less than 70? And again, you could have alerts set for that. And then you could have a ranking way of looking at this. And for example, this patient got flagged to be at the top of the list because they had more than 4% below 70. And so that would have been the first patient that the CD would have gotten in contact with. So the idea is, if you're going to have team members look through, follow 100 patients with CGM data, you got to have a more efficient way of doing that. And I would also argue that for this patient down here, who's wearing their CGM 100% of the time and has 96% time in range compared to 93% time in range the week before, and only 2% time below 70, that you probably don't need to do much communication with them in between visits because they're doing so well. So on to the phase 3 here, which was a Tableau-based tool, and been fun to work with the engineers because they come up with these really snazzy acronyms. So they're calling this TIDE, Timely Interventions for Diabetes Excellence tool. And so this is now the updated dashboard. We've got the names of the patients here blacked out, but you've got then what's the % time worn, what's that mean glucose, what's the time in range, % of time below 70, % of time below 54. And again, then coming up with a ranking algorithm so that you would want to reach out preferentially to this patient who had 8% of time below 70, but then second on the list is the patient whose average glucose is 350. And so one of the other things we're studying is how does that work? Do people respond to that well? And what should the proper cadence of that be? And then this is just a patient level display looking at some of the basic metrics that we all want, and kind of a quick way of looking at this. So you could click on one of the individual patients, and then it would take you to this AGP type of readout. And that's really the next step then, is to have this better integrated within Epic, and we're working to have an AGP type of view to make it even easier for our team. So one of the questions you may be asking is, okay, this sounds great, but there's no possible way you can scale this up, and that's why we've got that third specific aim to try to figure out how can we do this more efficiently. And so in the first phase, it was about 5 minutes per patient, but all patients were being reviewed. Well, you can do that when you have only 10, 20, 30 patients in. And then as the program grew, they developed this R-based tool. Still took about 5 minutes per patient, but were able, because of this ranking, to reduce by 40% the amount of who got reviewed in a week. And then we've moved on to the next phase, where it was down to about 4.2 minutes per patient. Just a lot of that's because of how the data got shifted and what CDE had to do. And then we're working on the Epic-based platform, and we'll continue to figure out how can we reduce that time per patient per review. All right, so how is this remote monitoring helping out compared to those who didn't get it in the pilot study? And so again, we had the 122, the first 46, this tool wasn't up and working. We've got similar characteristics on these different factors. Actually, we've got slightly more who are on, fewer who are on private insurance and more who are on public insurance in the remote monitoring because we were able to get funding to start everyone on CGM. So of those, we had 83 who had more than one review. There were a total of 828. And on average, there were about 10 dose adjustments that were made. So what this is back to our same figure with the A1c after diagnosis. The black line are those who got CGM but didn't get the remote monitoring, and then the blue are the 76 who were in that remote monitoring. You can see that there's about, depending on which part of the graph you look at, out to 12 months, we had about a 0.5% improvement among those who got the remote monitoring than those who didn't. And then this is just the unadjusted differences. And again, we're getting closer to 7% as opposed to the 7.5% by adding that remote monitoring in. Okay, so what does this look like? So this is what I showed you before. Basically, what we've added in is having this check-in with the getting the CGM started, and then also having the 1-week check-in via telehealth with the nurse practitioner to review CGM data, provide additional education. This has also helped us get patients more comfortable with telehealth, which I think has been really important for all of us in the last year. And then we've got this remote CGM data review that happens in between visits by the diabetes educator. So I haven't talked about the patient-reported outcomes. We're getting those baseline and every 3 months, and these are Kim Driscoll. These are, I think, some of the common questionnaires that you get, and Corey and team pick those out. And then what are the targets? Well, we're not inventing anything. We're using the targets that have been developed by NICE or ISPAD or ADA, and just to point out that ADA is now down at 7% for pediatrics as well. So using these in the standards of care with ADA, they do talk about how during the clinical remission period or the honeymoon period that you could try to aim for even tighter control. And I think that I think is always hard for us to change what goals we shoot for if you've been doing it a certain way for 10, 20 years. So I do think we'll probably shift a little bit more to try to have tighter control in the early phases after diagnosis. So we've had a few publications so far with this. One is a review that came out in the last year. Priya had a nice paper about CGM initiation, just to show it is possible. And then we've got a paper that we hope is going to come out soon. Molly Tannenbaum, one of our psychologists, did focus groups with about 20 of the initial families. Because one of the concerns is, okay, you think this is a great idea, but you're just overwhelming the families. And so the title of her paper is, I Was Ready for It at the Beginning, Parent Experiences with Early Introduction of CGM Following Their Child's Type 1 Diabetes Diagnosis. So we learned a lot from listening to these focus group parent comments and some teenagers as well. And hopefully we've improved our process, but I think this is kind of that plan, do, study, act cycle of trying to improve the care you provide. But I think this is an important paper because I think the question is, how early do you start this? You don't want to overwhelm people, and we've got some flexibility built in with the program and how we start it. All right, so future directions. We've now moved into the NIH funded part of it. We also have some exercise education that Desi Zarieva, who is an instructor with us, got a grant from Helmsley. We've got our first DSMB meeting actually later today. Don't have data yet on the PROs, and we'll be assessing outcomes 1 year out. We're also really working on these tools to scale on the population health management. It's easy to do something in 100 patients. How do you do it in 1,000 patients? And then Priya also has a program where we're trying to take some of these concepts and translate it into our existing patients, and particularly those who have public insurance in California, who may not have had the opportunity to get CGM in the past. And so we've got about 50 patients in that, and the Helmsley COVID funds that I know you guys had received as well has helped us try to scale that up as well. And what we're learning is there's some unique challenges with that group. So I am going to have one slide here to kind of follow up, and this is a great slide Priya put together. What can care might it look like in the future? You have the family, they get diagnosed, you get them on a CGM fairly early. We're able to see that data via GluVue. We're able to communicate, get that data into the electronic medical record, able to do telehealth with them. There can be alerts if someone is glucose level has gone way up, having more hypoglycemic time, able to see that, able to then get back to the family via telehealth method one way or the other, and kind of communicate that way with the goal of a lower A1c, more time in range, better quality of life, and decrease in hypoglycemia. And I also would say, we hope that the initial feedback we've gotten, it's also improved the quality of life of the care team, because we all have felt really good about seeing this data come back. And the diabetes educators feel good because they're actually applying the skills they have at the highest end of their license, which is to evaluate glucose trends, talk with the family, help them come up with solutions, make dose adjustments, and help educate. So it's been a good program for our CDEs as well. Again, lots of people to acknowledge on this. It's really a team effort, and that first T is intentionally teamwork. So just going to do about 5 minutes here to wrap up and kind of bring it back to, started with the T1D exchange, we went international, came back to what we're trying to do locally, and now would like to talk just a little bit about where I think, some of the data from the T1D exchange, but then also talk about the QI registry. I'm going to show just a few slides that Rehan Lal presented at ISPAD a few months ago. And what we're seeing here are the A1c average in pediatrics in the T1D exchange from 2010 to 2018 here in red. Then we've got the England and Wales NPDA group, and they were higher than us at the start, and you can see they've come down by about 0.7, 0.8%. And then you have DPV, who started low and has stayed low, maybe gone down just a wee bit, but significantly lower than the other two groups. So how have they done that? What were their quality improvement efforts? Well, with DPV, they've been doing this for 20 plus years. They've got benchmarking that they do. They have these regional quality circles, yearly meetings, they're publishing data, and they've had a performance that's been excellent and consistent, although they're pushing to do better. The NPDA, I think it's really impressive that they have had this improvement over the course of the last 10 years. And they've done all sorts of work with quality assurance, networking, having meetings discussing what they're doing and what's worked and what's not worked. And it's really been a mandate that they have to do these efforts. And you can see that they've gotten a great deal of improvement, and they're very pleased about that, although still wanting lower. Now, I think we're just a little bit behind in the US. The T1D exchange QI launched in 2016. There were 7 pediatric, 3 adult practices. There's now up to 30. And the participating clinics are sharing data and best practices. And there's a motto of shamelessly stealing from each other, or sharing. That would probably be better, to work together. If somebody figured out something that worked, well, let's share it and help each other out. So just a summary from those 3 registries. DPV's maintained their population A1c less than 7.7. NPDA has reduced it in a very clinically meaningful way. We really need to focus on how they succeeded, and we should expand our programs in the US to improve A1c. And so fortunately, that is happening. And I got UF is up here in the top corner. Here we are there at Stanford, and there's 30 clinics now with over 45,000 patients, both pediatric and adults, who are part of this network. And I think we're going to see some really exciting data at the ADA. There have been several papers that have already come out. There's really been a great source of data on COVID-19 and diabetes, especially in pediatrics. So kind of summarize here, and I think we've got some time then for some discussion, but there really has been a tremendous need to improve care and outcomes for people with type 1. I think the T1D exchange really expanded type 1 diabetes research. We need to improve our A1c and CGM glucose metrics for people with type 1 in the US. I think we've learned a lot from our partnerships with international colleagues to improve outcomes. Locally, we've got this 4T program. I think we've got promising pilot data. How do we scale this up to reach more of our patients? And then I think the T1D Exchange QI initiative is really focused on sharing best practices to improve outcomes. I think, again, I think there's going to be some exciting data coming out as that project continues to move forward. And I think we're finally on the right track here with this initiative to try to get better glucose outcomes with our patients in type 1 diabetes. I gave Toronto has a 100-year insulin. I gave there were maybe 5 or 10 slides I showed that presented in there, and that should come online sometime soon. But that really looks like it's going to be a nice conference. And then ISPAD has its conference coming up. Still not sure if it's going to be, hopefully it's going to be in Lisbon, but we'll see. If not, the virtual conference worked really well last year. And then just, again, thank you all for the opportunity to talk. Regret not being able to be in Gainesville and see friends. And I will stop the share there. Hey there, it's nice to see people again. But really a pleasure and an honor to get to speak to the University of Florida group. There's so many wonderful investigators, and friends going back, and Mike and Ashby with the ECHO program. We're on the phone a couple of times, or on the Zoom a couple of times a week. So wonderful to see everyone, and would be happy to answer whatever questions.
Thank you, Dr. Maahs. Great presentation. If anyone would like to ask a question, please unmute yourself. I think we have a question here in the chat box. From Christian Iglesias. Is the regional difference for HB A1c results presented comparing US and Europe data differ due to the amount of racial and ethnic differences in the countries?
Yeah, that's a great question. The honest answer is I'm not sure. I think Rich Bergenstahl and others from the T1D Exchange had a paper that came out looking at potential differences in hemoglobin A1c in Black population versus non-Hispanic white population. There was CGM data from, I believe, 3 months, and then how that related to A1c. And so within those two populations, for the same given CGM glucose value, there was about a 0.4% difference in hemoglobin A1c, higher in the Black versus the white population. However, if you look back at the data, we've got about a 1% or more difference. So, okay, there is a little bit of a difference there, but it doesn't explain the whole difference. And so I think it's going to be interesting to see how that difference of 0.4 gets followed up. But I think on a clinical basis, we got to figure out what to do with that 1%. And how do we deliver care better to all of our patients? And I think, going back to that editorial from Lipman and kind of that framework of thinking about some of the bigger factors in society and care delivery beyond what we're doing in a clinic are really important to consider as well. So I don't have a good answer for you. I think There's differences from one country to the other. I don't think there's any reason why the US and Australia should have higher A1Cs, for example, than Europe. I don't know that there's a whole lot of differences, say, genetically from, say, Australia and England. So I think what can we do as healthcare providers to improve it?
Thank you very much.
Hi, Dr. Maahs. This is Aiden Fernandez. I'm an undergraduate engineering student here. I actually have type 1 diabetes myself. But looking into the data you presented, I saw, or like I've seen this in other places too, but CGM data with connected to the pump, like CGM and pump participants are usually like have the lowest A1Cs on average. But mostly what was presented here was getting newly diagnosed patients on CGMs. Has there been anything looked into like as far as getting these patients onto pumps as well?
Great question. And we got to have a second stage of our study. So, right, so that probably will be, I think that may be where we are in another year or two. Right now, the T for technology, we've focused on getting CGM started early because we think, you know, gosh, my experience is when you go talk to an 8-year-old who's newly diagnosed, and you can say, I want you to either poke your finger 6 to 10 times a day, or you can wear this little thing on the back of your arm. Which one do you want to do? 95% of them choose the CGM. There's a few teenagers who don't. It tends to be teenagers who don't want to wear something. And then when you say to the parent, you can know what your child's glucose is 6 to 10 times a day, or we can start the CGM. We'll go up to the cloud. You'll know every 5 minutes. An alert can go off, going high, going low, at nighttime, et cetera, et cetera. So we thought, you know, let's start with the CGM, but then there's no reason we've written the protocol in such a way that, you know, I know of at least one family who got started on a control IQ within a couple of months. So that's fine. That's within the spirit of the protocol. But I think what you're saying, and I agree with, is should we formally say, okay, at 1 month, at 3 months, that there's kind of a checkpoint in a visit where it's like, hey, we're going to teach you about automated insulin delivery. And I think that's probably where we're going next. I think the data are looking pretty darn good that if you have these automated insulin delivery systems and the usability is high and you're lowering the burden on people as well, that you're getting better glucose outcomes. If you're getting better quality of life as well, that's a real win.
Okay, and the control IQ, that's through T-Slim, right?
Yeah, and you know, not to not to introduce any industry bias there. That's just one of them that's out there right now, right? Medtronic has a system as well. Medtronic's working on another system that looks really promising. Omnipod has partnered with Dexcom. They've got a system that is at the FDA for review. And then we've got the Tidepool application with the DIY systems that are coming out. So, you know, I showed you, well, we've been using Dexcom early, and the main reason for that is we can get the data up and into our system via Apple Health Kit. And right now we can't do that with Libre 2.0, and also Libre doesn't have, you know, there are apps you can download, but it doesn't have that remote monitoring or remote sharing in the same way that Dexcom does. So we would like to be able to be completely agnostic to the type of device. And if you want one system versus the other system, that's fine. That's your choice as the person with diabetes and the parents who are going to pay for it, right?
Yeah, awesome. Thank you.
Hey, thanks, Aiden.
More questions?
How are you doing, Des?
I think he's on mute. Like
no, I was trying to get off. You know, I guess that'll be the. You know, people will be writing essays on muting and unmuting yourself in the future. No, I think, David, you've given really a tremendous overview of where we're headed. I think, it's interesting. We have several psychologists on here, and we're all aware of the burden, which you described well, the burden of technology. But we've got to look at this certainly in the context of really has technology really benefited kids? And the answer obviously is significantly, particularly in the last couple of years, and particularly as you just went into with the automated closed loop systems, particularly when combined with CGM. But really fabulous talk. That's what we expect out of you, and really thank you and Ashby and Mike and others for arranging this talk. We're really honored to have you, and it's always a pleasure to work with you. So thank you.
Well, thanks, Des. And like I said, regret I couldn't be there in person, and would love to get down to Gainesville and see the campus. So
we'll do it again.
Oh, awesome. All right, Mike, I don't think we've got a Zoom for another 3 hours.
It's a long break for us. But thank you for joining us, David, all the way from California. We enjoyed it.
Okay, pleasure to see everyone.
Working.
Send me any questions if you think of them. Happy to try to answer.
Bye, everybody.
Thank you, David.
Thanks.